Hello, it's my privilege today to discuss recent evidence on anticoagulation in patients with COVID-19. These are potential disclosures. There's been growing interest in the cardiovascular manifestations and hypothetic mechanisms related to cardiovascular manifestations in patients with COVID-19. Particularly, one cardiovascular manifestation which are intriguing, researchers and physicians are the thrombotic risk, the risk of, plaque instability and rupture, the risk of microvascular thrombosis, the risk of venous thromboembolism. Patients hospitalized with COVID-19 have a lot of risk factors for thrombotic events. Once again, both arterial or venous thrombotic events. And that includes the classic risk factors like acute illness, sepsis. Is well known that patients hospitalized with COVID-19 also have lots of risk factors for these events. Several of these patients had established cardiovascular disease like heart failure or atrial thrombotic disease, besides other important comorbidities that increase the risk of thrombotic events like malignancy, COPD, and chronic kidney disease. And it's been noted by observational studies that patients with COVID-19, they can suffer pulmonary embolism, deep venous thrombosis, myocardial infarction, and stroke. And besides the arterial and venous thrombosis, it's also been described by some mechanistic studies and some early studies that patients with COVID-19, especially patients with comorbidities, are prone to localized intravascular coagulation. Of course, due to the thrombotic risk, empirically, several hospitals and several physicians are starting therapeutic anticoagulation for these patients. But I'll say that before we empirically start therapeutic anticoagulation, we need to conduct the proper randomized trials and systematic reviews and meta-analysis. So sometimes the answer to a complex problem is not simple, but requires the conduct of sound evidence. Recently, I have published an editorial in The Lancet, and to create exactly the awareness for the need for large-scale, simple trials to answer questions, for example, with respect to anticoagulation, before we start empirically treating several patients with this type of therapy. Of course, anticoagulation also has harm related to it, especially major or non-major clinically relevant bleeding. So before understanding, the sweet spot or the balance between efficacy and safety, we need to conduct such trials. And a lot of recent trials testing antithrombotic therapy are being either completed or underway. That includes trials with heparin-based regimens, including fractional heparin or low molecular heparin or other therapies. So currently, we have 2 trials in the outpatient setting with heparins, 25 trials, so several studies in patients with COVID-19 of moderate severity, and 17 trials in patients which are critically ill with COVID-19. We also have ongoing or completed trials with the DOACs. We have, in this case, 7 trials in the outpatient settings, 6 trials in patients of moderate severity, and 2 trials in post-discharge patients. Recently, our group here in Brazil completed the ACTION trial. This trial was presented at the American College of Cardiology 2021 late-breaking clinical trial session and was published in The Lancet recently. The ACTION trial compared therapeutic versus prophylactic anticoagulation for patients admitted to hospital with COVID-19, and all patients needed to have an elevated D-dimer. You already seen my disclosures. Here are the study oversight. So the action trial was led by an executive committee composed of several colleagues from different institutions. This is what we call in Brazil the Coalition COVID-19 Brazil. The Coalition COVID-19 is a group of researchers, and once again, from several institutions that are conducting different large-scale randomized trials in several sites in the country. In the action trial, we included patients aged greater than 18 years who were hospitalized with a confirmed diagnosis of COVID-19, and duration of symptoms related to hospitalization needed to be to a maximum of 14 days. As I previously mentioned, all patients needed to have an elevated D-dimer. These patients were randomly assigned in a concealed fashion. We ended up including 615 patients who, once again, were randomly assigned in a concealed fashion to either therapeutic anticoagulation or prophylactic anticoagulation. In the action trial, we included both stable or unstable patients. In the case the patient was stable at baseline, the main therapeutic regimen included in-hospital rivaroxaban 20 milligrams daily, followed by rivaroxaban through 30 days, the same dosing, irrespective of the duration of hospitalization. And in case the patient was unstable, the key therapeutic strategy was based on enoxaparin. The primary endpoint for the action trial was a hierarchical analysis of mortality, duration of hospitalization, and duration of oxygen use through 30 days, a composite endpoint. So besides this primary endpoint, we also had a primary safety outcome, which included major or clinically relevant non-major bleeding according to the ISTH criteria, and key secondary outcomes, which included mortality, myocardial infarction, venous thromboembolism, stroke, or a major adverse limb events. All the endpoints were adjudicated by a CEC committee. The statistical analysis, the main analysis, followed the intention to treat principle, thus including all randomized participants. For the primary analysis, the analysis for the hierarchical composite primary endpoint, we used a methodology called the win ratio. In this case, a ratio greater than 1 reflects a better outcome. Why? Because for the primary outcome, it is calculated by the total number of wins divided by the total number of losses between the two study groups between each strata. Secondary endpoints were binary endpoints, and we conducted analysis based on log binomial models and reported results according to the relative risk as the main effect measures and its respective 95% confidence interval. So this is how the win ratio works. All patients contribute to this outcome. So this is interesting because we maximize the statistical power of the study, taking the best of all the information available from all patients included in the trial. So we do a comparison of patients from each group in a hierarchical fashion. First, we compare groups according to mortality, and we count the number of wins, the number of ties, and the number of losses. Comparing, of course, the experimental group, which is therapeutic anticoagulation, versus the control group, which is prophylactic anticoagulation. Then, hierarchically, the second component is compared between groups, which was duration of hospitalization. Once again, we count the number of wins, the number of ties, and the number of wins to the prophylactic group. And finally, the same holds true for duration of oxygen use. So let's see the results of the action trial. Here are the baseline characteristics. As expected, in a moderately sized trial, baseline characteristics were well matched between groups. The mean age was 56 years. Around 60% of included patients were male. Majority of included patients had comorbidities. For example, half of our population, or almost half of our population, had hypertension. Around 25% of the included patients had diabetes. Most patients were included in a so-called stable condition, 93% of them, most of them of moderate severity at baseline. In terms of use of evidence-based therapies, for example, systemic steroids were used at baseline by around 82% of the included patients. Here the results are for the primary outcome in the ACTION trial. Once again, this was a hierarchical analysis of mortality, duration of hospitalization, and duration of oxygen use through 30 days. So once again, we will compare the number of wins and the number of ties. So there were 33.9% ties. Here in blue are the number of wins favoring the prophylactic group, the control group, 41.3%. And here are the wins for the therapeutic or experimental group, 34.8%. Remember that a win ratio greater than 1 would mean more wins favoring the therapeutic group. In this case, the opposite happened. We had more wins in the control group, in the prophylactic group, which here is reflected by a win ratio of 0.86 with a 95 confidence interval ranging from 0.59 to 1.22. So there was not a statistical significant difference between groups, but of course we had more wins in the prophylactic group. Here are the components of the primary endpoint. So we had more wins for mortality favoring the prophylactic group. We had slightly more wins in terms of duration of hospitalization favoring the prophylactic group, and more wins on duration of oxygen use, once again favoring the prophylactic groups, and you already seen the number of ties. So in our trial, therapeutic anticoagulation was not superior to prophylactic anticoagulation, and actually the opposite happened. There was a trend of being worse than prophylactic anticoagulation. All-cause mortality was increased when we compare therapeutic versus prophylactic anticoagulation. We have a 49% increase in mortality. This difference was not statistically significant, but as you can appreciate, there was more events in the therapeutic as compared to the prophylactic group, without, once again, statistical significance between them. Here are the safety outcomes. Remember, our primary safety outcome was adjudicated ISTH, major bleeding, or clinically relevant non-major bleeding. There was a 3.64-fold increase in clinically relevant bleeding when we compare the therapeutic versus the prophylactic anticoagulation group, and this difference was statistically significant. So an increased harm. Not only therapeutic anticoagulation had more losses than prophylactic anticoagulation, but it also increased harm in COVID-19 patients, which were hospitalized both in stable or unstable condition at baseline. So in conclusion, a strategy based on a DOAC did not seem to influence favorably outcomes in these patients. But as I showed you before, there are several ongoing trials of anticoagulation in COVID-19 patients. This is a very interesting initiative, is a platform trial, which includes different studies like the ATTACT, ACTIV-4, PROTECT, and the REMAP-CAP studies. Almost 3,000 patients included in the United States, both patients of moderate severity and patients which were critically ill. We don't have the final publication of this platform analysis of different trials, but we have some interim analysis reported and some preprint results being reported. But of course, we still wait for the final publication in order to deep dive into more details. What we learned so far and what we know so far is that for patients of moderate states, the therapeutic as compared to prophylactic anticoagulation was superior. So the probability of superiority was greater than 99%. So it seems to favor uh, positively the primary outcomes in these studies. And in patients who were critically ill or in patients in a severe state, there was futility and no difference between groups. Once again, we need to wait for the peer review publication in a high impact journal in order to have more details. Nevertheless, once again, in patients of moderate severity, the primary outcome of organ support 3 days was better in patients treated with a therapeutic anticoagulation. A key difference between this platform analysis as compared to the action trial that here the therapeutic anticoagulation was based on heparin as opposed to our trial where we base it mainly the therapeutic anticoagulation strategy, unadoc in our case, rivaroxaban. And as you've seen, there was no difference in patients which were critically ill. But once again, I think we first need to wait for the results of several ongoing trials before recommending, to a broad spectrum of patients, the use of therapeutic anticoagulation. So there's more to come. So stay tuned. And I thank you very much for your attention.